Good afternoon. I'd like to call this hearing of the Pennsylvania House Health Committee to order. Today we will be hearing a discussion and testimony on the topic of community health workers, an important element of our healthcare structure. It's a truism that only a small fraction of our healthcare comes from our appointments in doctors' offices. In fact, where we live, how we live, our DNA and our zip codes all influence our health. Community health workers help bridge the gap between our doctors' offices and our neighborhoods, making sure that we all have the best opportunity to increase our health. Today we'll be hearing from organizations that employ community health workers and our foundation community which supports them. But mostly, we'll be hearing from the people engaged in this work on a day-to-day basis who can explain why what they do matters so much to the people they work with and why it matters so much to us as policymakers. I want to thank all the members who came in person, and I think that's a small group because we have competing meetings today. We have appropriations hearings, and some of our members are there. I think they'll be coming in. We have some folks online, which I will introduce the Democrats shortly. And before I pass it off to my counterpart, Representative Twardzik, who is filling in for Chair Rapp today, who I think might be online at some point, I'd like to mention that we have virtually with us today Representatives Schusterman, this is Democrats, Representative Borowski, Representative Howard. We expect Representative Venkat has told us he will pop in at some point. And I know there are, again, members of our committee who are on appropriations who may be coming in as well. So let me turn this over to Representative Twardzik to any opening remarks and introduce those who may be online and who are here.
Thank you, Mr. Chairman, and thank you for coming in on this beautiful day in Harrisburg at one of the most beautiful state capitals. So stick around for a tour, but it is nice to have you here. Looking forward to your information. We do have Representative Joanne Stair with us, who in her prior life was in healthcare. And on board, we have Jamie Walsh, Representative Gary Day, and Representative Tim Bonner. So thank you for coming. We'll get right into it.
Thank you, Representative Twardzik. We have two panels. Our first panel is a panel of actual providers. We have George Garrow from the Primary Health Network, and he is its CEO. We have Tia Whitaker, CHW, PA Association of Community Health Centers, and we have David Wiles, also a community health worker, who is the CCHW Board Chair. So I will leave it to the three of you. Why don't we just start off in the order that I... we're going to start with David Wiles. Okay, David.
Thank you. I got this thing right? Perfect. Okay. Good afternoon, Chair Frankel, Representative Twardzik, and members of the House Health Committee. My name is David Wiles. I'm a certified community health worker and the executive director of the Pennsylvania Community Health Worker Collaborative. As the executive director of the State Community Health Worker Collaborative, I stand before you, well, in this case, I sit before you, representing the over 650 certified community health workers in Pennsylvania and the over 500 members of the Pennsylvania Community Health Worker Collaborative. Thank you for the opportunity to testify today. We are here to provide information on the CHW workforce, otherwise known as your neighborhood heroes, and to urge you to prioritize the inclusion of community health worker services as reimbursable under the Pennsylvania Medicaid program. This workforce has been shown to effectively address health disparities seen by our most vulnerable and underserved communities. Pennsylvania faces critical challenges, clinical workforce shortages, ongoing concerns about health equity, and the need to deliver better outcomes at lower costs. The Commonwealth's community health workers are well poised to address these needs, improving access, outcomes, and health equity while reducing medical assistance costs. Community health workers have been a critical part of our health workforce for decades. This workforce is at risk of ending due to the lack of current methods to financially sustain the workforce here in Pennsylvania. In 2023, over half of the CHW positions were funded by short-term grants here in Pennsylvania. From 2021 to 2024, a program funded by the CDC integrated community health workers into nearly 2,000 organizations and reached over 20 million people with services and education across the nation. I was one of those community health workers, and my job would have ended in August 2024 due to the ending of these funds. For years, I worked as a community health worker for Cornerstone Care, which is a federally qualified health center providing services in southwestern Pennsylvania. The majority of my time with Cornerstone was spent serving the community of Clairton in Allegheny County. Clairton is an urban area and is home to U.S. Steel's Clairton Coke Works, which is the largest coke manufacturing facility in North America. Clairton was once a booming city with a population of almost 20,000, but with the decline of the steel industry, it has been suffering from a steady population decline, resulting in economic fallout, and is now below 6,000 people. I would regularly meet with people who remember Clairton having movie theaters, bowling alleys, and more. Now it is a food desert, a place where people heavily utilize the emergency room for care if they can get to it or seek it, and a place with limited to no positive outings for the youth outside of school-sponsored activities. When you feel that you are on your own, you begin to build walls to protect yourself, you grow accustomed to no outside support, and the support that comes is usually short-lived, which further builds these walls. This is true in urban communities like Clairton and rural communities like Marion Center, which I grew up in Indiana County, thus posing the question, how do you break down these walls? How do you connect individual needed services to families that have grown accustomed to living with less and no outside support? I found one thing to be true from my years growing up in rural PA, in providing linkages to care in urban settings as a community health worker, and that is that trust is the key ingredient to instill change. These siloed folks feel obligated to push through injuries and all sorts of health conditions to feed their families. I saw this play out my whole life. For a while, I thought this was even the way of life. However, I began to see this as unfair. These folks aren't living this way by choice, but by necessity or the thought that it is. The reality is heartbreaking, unnecessary, more costly to taxpayers in the long run, and not what I believe the state stands for. However, there is a way to improve the quality of life for these families that is both effective and cost-effective, and that is through the use of community health workers. A community health worker is a trusted member of their community who leverages lived experience to contribute to improved health outcomes. Community health workers serve the communities in which they reside or communities with which they share ethnicity, language, socioeconomic status, or life experiences. They get to know individuals and families in their communities and provide tailored social support, advocacy, navigation, and coaching to help them improve their health and well-being. In other words, they know their communities and meet people where they are, quite literally in that we will come to your home if you'll open your door to us. Community health workers' superpower isn't years of study, it's their ability to connect with the people they are helping, taking the time to listen and understand each person they work with and meet them with where they are in language that they understand. A large body of evidence shows that community health workers improve chronic disease management, mental health, and reduce healthcare costs. With a growing need for culturally and linguistically responsive primary care, behavioral health, and social services in Pennsylvania, community health workers are uniquely positioned to increase access to primary and preventative health care, lead interventions such as symptom screening and care planning that can result in improved outcomes in chronic diseases such as health disease, diabetes, maternal and child health, reduce cancer disparities in the prevention of infectious diseases, and provide potential cost savings across care settings. One study found that every $1 invested in CHW interventions resulted in a return on investment of $2.47 within the fiscal year. That was here in Pennsylvania. Community health workers are employed by both clinical and non-clinical employers. However, regardless of their employer type, they do not provide clinical services. They are employed by federally qualified health centers, community-based organizations, healthcare systems, and health plans. Community-based organizations and FQHCs employ over 50% of the CHWs in the state, largely because they are the employer type most commonly embedded in the community. Community health workers are a true profession. Since 2020, Pennsylvania has offered a voluntary CHW certification through the PA Certification Board. For a community health worker to become certified, they need to complete a minimum of 75 hours of education through a PCB-accredited CHW training provider. have 1 full year of full-time volunteer or paid employment experience, or the equivalent of 2,000 hours of part-time volunteer or paid employment as a CHW. They need to have 60 hours of on-the-job supervision of qualifying work experience specific to the training domains. This is a 2-year certification with a requirement of 30 hours of relevant continuing education for recertification. Please see my testimony for more information about certification. And all of this is bringing us to where we are today around community health worker sustainability. Since April of 2023, PADHS has worked with us to develop a state plan amendment that will authorize payment for community health worker services that had an initially anticipated start date of January 1 of this year, 2025. This was then delayed until July 1st, 2025. And then last summer, in August of 2024, we were informed that the SPA was delayed again with no anticipated start date. Many community health worker programs funded since the end of COVID-19 are ending or have ended, and PA communities will lose valuable resources. We have heard that the Department of Human Services has changed their mind about the state plan amendment and would prefer to incorporate the work of community health workers into the PA Health Choices contract. This is an idea we would be willing to consider, but it hasn't been discussed by them in any of our recent meetings. The current offerings through the community-based care management program are not sufficient, but we would be open to discussing new language around this. DHS facilitated listening sessions through January, which turned into working groups in January and February of this year. Community health workers and allies across the state devoted their time to make sure their voices were heard. At the end of it all, we've been told that those who participated will not have the opportunity to view or comment on the final report given to the Department of Human Services. We urge you to support community health workers in PA communities by keeping DHS accountable for this progress, and I thank you for your time.
Thank you very much. I just want to note that before we go to our next testifier that we've been joined by Representative Benham. I cannot read that. Devin, you keep me posted of who comes online. And our next testifier is going to be, go ahead, George Garrow. Yeah.
How about now? That's great. Okay. So thank you very much for this opportunity. My name is George Garrow. I am a physician, and I am really honored to serve as the Chief Executive Officer at Primary Health Network. And for those of you who may not be familiar, Primary Health Network is a federally qualified health center located here in Pennsylvania. We're the largest FQHC in the state of Pennsylvania. Primary Health Network serves about 75,000 patients each year. We're located in 16 counties here in Pennsylvania and 1 in northeastern Ohio. And the mission of community health centers in general is we're there to provide access to high quality, affordable health care to everyone in the community, regardless of their ability to pay. I practiced as a physician. I'm an oncologist by training. And I joined the health center movement at Primary Health Network about 8 years ago. And what really attracted me to come to work at a community health center was the mission of service to individuals in the community who haven't had all the advantages in their life that I was blessed with. And very commonly, if anyone had asked, and sometimes even if folks didn't ask, I would say that serving at a community health center was the best job I ever had. I joined as the chief medical officer, and then about 3 years ago, I'm honored to serve as the CEO. And yeah, this is the best job I've ever had. I'm very, very grateful to sort of shine some light on, as a healthcare provider, what having access to community health workers means to our patients, to our community, and to the healthcare delivery system. Primary Health Network currently employ 12 community health workers across our footprint. Again, we're broad. We range from the eastern suburbs outside of Philadelphia, Schuylkill County, and we go as far west as the Ohio border. We're as far north as Erie and we're down as far south as Westmoreland County and a lot of small rural communities in between. I used to think that as a physician that I was the single most important person in someone's care delivery. And I have very humbly learned, sitting here next to David and to Tia, that I am not. Physicians, nurse practitioners, other prescribing providers play an important role in setting the path for care for our patients. But it really is the role of community health workers to help us to implement those changes and the care plan in order to try to help our patients achieve optimum health. You've heard us talk a lot in healthcare. We talk a lot about social drivers of health or social determinants of health, which are social barriers that prevent people from achieving the optimum health that they desire. And my partners that serve our organization as community health workers are extremely important in helping us to fulfill that mission of navigating them to achieve optimum health. And we really do this as a healthcare provider. We really do this in 5 ways that we rely on our community health workers every day. They're present in our healthcare clinics. They're an important part of the care team. We have huddles every morning, and we talk about the patients who are coming in for the day, and at the end of the day, we huddle up again and we talk about the patients that we saw today and what do we need to do to drive their health forward. And the community health workers are an integral part of that team. They sit with the physicians, the nurse practitioners, the nurses, and others to help understand and what are the needs that the patients need after they leave. The second important thing that our community health workers do is they provide outreach and education. And importantly, they educate patients on the importance of preventive care and primary care services. You all are very familiar that we spend an awful lot on health care per capita in this country, but our health outcomes leave a lot of room for improvement. And truly, I believe that leaning into preventive care and primary care is a way that we try to bend the overall cost curve in health care. The third way that community health workers help us to meet the needs of our patients is they connect patients to essential community resources. And with your permission, I'd like to share a couple of examples of real-life stories that just happened within the last few days in our health center and how community health workers helped our patients to access those necessary services. Now, I'm in healthcare, and I kind of know my way around the healthcare system, right? I've been in this world for a long time, but it's very complicated, right? And we've all experienced that firsthand. And it's very, very complicated for patients who may not have high healthcare literacy or have other challenges. And I think an important part that our community health workers play is they help our patients to navigate the complexities of the healthcare system, helping them to get those appointments scheduled with specialists or to get to those appointments when they are needed. And then finally and importantly is follow-up support. It's not a one and done. As David had mentioned, they're part of the community, they're trusted members of our community, and they're there to really continue to help us to regain the trust of vulnerable patients in our community. I should point out that our community health workers service all individuals, whether they have commercial insurance, whether they have one of the managed care plans, whether they're on Medicaid, or if they're uninsured, it doesn't matter. All patients have access to our community health workers, and they do a really terrific job. So with your permission, I'd like to share just 2 examples that have just occurred within the last few weeks. A couple of weeks ago, I was leaving our facility in downtown Sharon, and we have a pharmacy on the ground floor. And I was on my way out to attend a meeting, and I happened to look over, and the pharmacist was interacting with a patient, and she was very distressed, and she called me over. So I went over, and I said, how can I help? And she was educating this young man on how to prepare and to store his insulin. He had just met with our physician in our family medicine practice, and unfortunately his diabetes, we couldn't get it controlled with diet and exercise and oral medication, so decided he needed to prescribe insulin. And the pharmacist was explaining the importance of storing his insulin in a refrigerated manner so that it would have viability and longer half-life. And as she was educating the patient about the use of his insulin, he reported that he doesn't have a refrigerator In fact, he doesn't have a house. He lives under a bridge. So what an eye-opening story for me. I take for granted that, again, folks have resources that I take for granted. But until we address this person's housing situation and find him some stable housing, no matter what we did to prescribe him his insulin, we weren't going to accomplish our goal of controlling his diabetes. And so first person I called was our community health worker, who ran down, met with the patient, spent a lot of time understanding their needs in a non-judgmental way, and help them get connected to stable housing. And I'm pleased to report that over the last couple weeks, the patient has been able to use his insulin and his diabetes is in better control. So that's one example. And the other example actually just happened on Friday at one of our mobile health clinics in Lawrence County. We actually have a great partnership with the City Rescue Mission, which cares for individuals who are unhoused. And we take our mobile unit down there to provide clinical services to the men who are part of the City Rescue Mission. And our nurse, who was at the mobile unit, a patient walked up and his face was really red and swollen. And he had mentioned that he was unhoused and was seeking care at our mobile unit. And the nurse and the physician who were on our mobile unit realized that this patient had a dental abscess, and this required pretty important and prompt care. So to the rescue came our community health worker, who met this young man and contacted a chaplain who is working with us at the City Rescue Mission, and together they were able to navigate this patient to the emergency room so that he could get started on intravenous antibiotics to get his dental abscess under control. The other important thing that our community health worker learned when she was interacting with this young man is that his mother had died just a few days earlier. And we were able to offer him psychological and emotional support during his time of grief. So those are just, I think, two really important real-world examples of the value that community health workers bring to our community, to our patients, and certainly bring to me as a healthcare provider. Thank you for your time.
Thank you, Dr. Garrow. Our last panelist on this first panel is Tia Whitaker.
Testing? Yes. Good afternoon. Thank you so much to the members of the House Health Committee for convening us today. Thank you for this opportunity also to provide written testimony. So my name's Tia Whitaker. I am a certified community health worker, and I'm here today to express my strong support for sustainable funding for community health worker programs within Pennsylvania. Community health workers are employed by many employer types, but I'm focusing on community health workers, or CHWs, at community health centers. There are 53 community health centers across the Commonwealth. Many of them serve rural communities. My testimony focuses specifically on the invaluable non-clinical work CHWs provide to children and families and the impact that they have on services that need to be provided. For many years, I've witnessed firsthand the impact that community health workers have at the Pennsylvania Association of Community Health Centers. I've seen firsthand the profound positive effect CHWs have on the most vulnerable populations within our Commonwealth. For example, we'll call her Jan. She was losing her eyesight. She had macular degeneration. She was unemployed. Her husband was of Medicare age, so he had Medicare, and he had Social Security. And she met with a community health worker to talk about her insurance. She said, "We're paying so much for our insurance. We can't do a lot of things that we would like to do." So after many hours and several visits, she was able to get insurance and coverage through Pennsylvania Health Insurance Exchange, through Penny. Her deductibles, her co-pays were lowered, and her premium cost was cut by 2/3. And what stuck out to me was she sat and she cried, and she turned to her husband and she said, "We now can talk about going to visit our grandchildren in Arizona." It had been 6 years since she had seen her grandchildren because she could not afford the co-pays, the deductibles, and the medications that she was on. Had she not met with a community health worker, she would have continued along those same lines and not been able to visit her family. We understand the value of community health workers. Unlike clinical providers, like Dr. Garrow, CHWs bridge the gap between the healthcare system and the community, providing essential non-clinical support that directly addresses social drivers of health. Community health worker intervene specifically, and they benefit children and families by navigating complex health systems. CHWs assist families in accessing critical resources such as food assistance, the SNAP program, housing supports, childcare, and other educational opportunities. A homeless man was seen for hyperlipidemia with open sores. He ended up going to a community health center and meeting with a community health worker. The community health worker averted him going and accessing care at an ER. She worked with him and worked with him and worked with him to make sure that he received the medications that he needed, to make sure that he had all of the additional supports that he needed. Come to find out, he was also homeless. So she worked many, many hours to make sure that he was able to be housed, he was able to be sheltered, and he had her contact information so that he could reach out to her specifically for any additional needs that he had. Community health workers also provide health education and promotion. They provide culturally appropriate education on topics ranging from nutrition to healthy eating and immunizations. So a patient comes to a community health center with no insurance and needed a critical surgery. Meeting with a community health worker changed her life. She applied for emergency medical assistance. We're talking about medical assistance, we're talking about healthcare, we're talking about resources. These are the things that people need, and they can't always get to the resources that they need. However, community health workers know what's available in the community at the health center and other state agencies. So in order for her to remain housed, finding care and finding a home and some place to live, she had to maintain employment. Reached out to the community health worker. How do I maintain employment? I don't have a job. Community health worker works with the local earn centers, helps the patient look for employment, helps them sustain that employment. There's nothing better than when a patient comes back to you and says, I'm so thankful that I met you. I'm so thankful that you're helping me, and I'm blessed to have you in my life. That's the original testimony. Community health workers also provide disease prevention and management support. For families managing chronic diseases, community health workers provide vital support to ensure medication adherence, scheduled appointments are kept, and also help to manage other symptoms. As a community health worker, I work with those who have been diagnosed with cancer, those who are cancer survivors, those who are cancer caregivers, and other chronic diseases. The focus is not just on a disease, but it's also on the fear, the anxiety, and the panic that comes when you get a diagnosis. You have someone who's a community health worker who's able to say, let's take a deep breath. What do you need? Because when you get a diagnosis, you're not always thinking clearly. But community health workers have the ability to reach out, to handhold, to walk through the process and provide those additional resources that folks need when they might hear the big C, they might hear cancer, or get another diagnosis. Community health workers also provide early childhood and developmental support. A young mother of 2 needed assistance with pediatric development. She didn't know where to go. She ran into a community health worker. Community health worker was able to assist her with her major initial boundary was lack of transportation. So she was able to get her connected with Rapid Transit and say, okay, this is what you need to do. We'll help you get a bus pass so that you and your children can get to your doctor's appointments. After getting to those doctor's appointments, also linking her specifically with other resources to make sure that the early interventions that her child needed were available. Community health workers also help out with mental health support and link to care. A 66-year-old female patient with intellectual disabilities, limited short-term memory, and some mental health and behavioral health diagnosis was not established for care anywhere. Reaching out to a community health worker through word of mouth, she was able to get established with care at a community health center. She also needed assistance getting a Social Security card, obtaining her birth certificate, getting a photo ID, the things that we take for granted. She wasn't able to get any of the services that she needed because she didn't have the needed documents. She was also able to apply for medical assistance, transportation, and other food services. Both the clinical team and the non-clinical team at the Community Health Center worked closely with her to ensure that she was able to get everything that she needed. The results of community health work interventions are tangible. We see fewer children admitted to the hospital for preventative conditions, reduced ER visits, and other manageable conditions. Community health centers account for $1.1 billion in savings to the Pennsylvania Medicaid system and $1.8 billion in savings to the overall healthcare system. Pennsylvania's community health centers have seen a 4-year patient growth of 17.2%, with more than 3.6 million visits. Investing in community health worker programs is an investment in health and well-being of Pennsylvania's children and families. It is a cost-effective, preventable strategy that leads to significantly improved long-term outcomes and ultimately saves healthcare resources in the long run. I strongly urge you to support community health workers and recognize them under Pennsylvania Medicaid. Thank you.
Thank you. Thank you very much. Thanks for your testimony. Yeah, I want to note we're also joined by Representative Gina Curry. Let me start off a question. What is the difference between a community health worker and a social worker?
Social workers deal with social and emotional needs, and community health workers deal specifically with resources and things that affect consumers' environments.
Am I able to add to that question?
Sure,
I also
absolutely.
think, too, it's important to note that a community health worker's role in that, it can be comparable, but the community health worker will often spend time going to the client or patient's home to provide the care, too. So it's really meeting the folks where they are, not always in so much of a clinical setting, but can be on the street, can be in your home, can be in the office, but they can provide care anywhere to make sure those connections are made.
And from, obviously, the main issue we're looking here is getting reimbursement under Medicaid. Is the work of community health workers reimbursable now from, I know this is probably not a common thing, but private payers and Medicare?
It is now, as of 2024, reimbursable through Medicare. However, I'm not certain how many claims have been submitted here in the state specifically. We actually put out a survey here at Patch with the Pennsylvania Community Health Worker Collaborative to survey our membership to see how many claims have been submitted, and our responses were not detailing many, if any, at all. So I'd have to follow up on that data to respond, but it is something that is reimbursable through Medicare now in 2024, but not heavily accessed due to some barriers that are in place to actually submit those claims.
So currently, it's funded basically through the FQHCs or grants, so, you know.
Very heavily grant funded, yes. Short term.
Right. Thanks. Other members have any questions or comments? Representative Benham.
And this can be for anyone who wants to answer it, but can someone talk a little bit about the impact of this funding model on sustainability, workforce shortages, and so forth?
I'll try to address that if that's okay. So Fortunately, in the FQHC world, we do have access to some funding, and particularly through some of the short-term grants that David had mentioned. The sustainability of this is obviously heavily dependent, and those grants are not always something that we can rely on year after year after year. We are committed. I'm personally committed to doing whatever we can to continue to have our community health workers, because they're such an integral and important part of our care delivery team. I mentioned earlier the impact of social drivers of health, and so many patients are not able to achieve optimum health because they lack the ability to access those resources to address those social drivers of health. And the value of the community health workers helping to address them, as Tia and David had mentioned, helps to keep people out of the high-cost centers of care, to keep them out of the emergency room so they don't need to access the high-cost centers of care. As we lean into preventive care and primary care, hopefully we can avoid unnecessary or avoidable admissions. And certainly if we're able to control patients' chronic diseases better, we may be able to keep them from needing to go to intensive care units and other very high-cost centers of care. So it's really looking at a way to bend that cost curve, using our resources wisely, and spending it in areas which is really heavily on preventive care.
So ultimately, if we invest in this model, we save money over the long term, I think is the argument, and certainly is the claim that David has made many times in my district office. Shout out to folks who have traveled from back home.
Other questions, comments? Representative Twardzik?
Thank you, Mr. Chairman. Mr. Wiles, in your written testimony, you indicated the Department of Human Services is working on a state plan amendment and to authorize the payments. The testimony states that this amendment has been delayed. Can you share with the committee what's causing this delay, and is there an expected time frame that DHS will be submitting?
Thank you for that question. I'm happy to respond. We don't have the total clarity just yet as to why the state plan was initially postponed. That's actually something we're hoping today, by asking and having this hearing that you all put together, and we're thankful to be here, to see if we can get more to the root as to why the delays have been happening, because the communication that we've had with the department has kind of halted since the delay, which took place in August of last year. And that then led to more of a step back and working with Deloitte to put together those listening sessions in working groups, which are now putting not a white paper, but a document to help inform the department's process on the state plan amendment, which is due to be submitted in March. And following that document, we're uncertain what the timeline would be, and we're hoping that an outcome of this hearing can be to see more of when they'd be willing to put that back on the calendar and then holding them to that timeline.
Okay, thank you for that answer. Appreciate the information and everything that you've shared with us. Are there any states currently covering community health workers?
There are
So we can try to use that plan to...
South Dakota is a great example. Some neighboring us too. New Mexico recently had a good state plan amendment. There's, I believe, 16, but 3 more in process, so 19 in total of the 50 states that we can mirror. But some of the greater ones that we utilize, and I believe are in the written testimony I submitted, would be South Dakota would be a good reference, just due to their limited barriers for community-based organizations to be able to submit payment, which are, again, the largest employer of community health workers in the Commonwealth and the nation. So mirroring some of their practices to make sure that they're able to be in this model, to make sure that if we do have a state plan, it's one that's effective to all the communities and is as good as it can be. So,
Okay, thank you very much.
Representative Curry.
Thank you, Chairman, and thank you for having this hearing today. I'm sorry, I'm part of Appropriations Committee, so I slipped out for a second to come down here because I think that this is such an important conversation. Some of you in the room know that I work closely with the Women's Health Caucus, and I'm a co-chair of the Black Maternal Health Caucus here in Pennsylvania. One of the things that, when I think about community health workers I think about the importance of having community health workers decrease the number of folks that can get to places of good health care because of lack of access. Now, you know, we have many hospital closures that are happening across our state, unfortunately. One of them is in Delaware County that I'm dealing with right now, and I see friendly faces in the room from Delco. One of the things that I think about in the work that I do with maternal health is the fact that we have birth workers. Is that something that's similar to community health workers? Can you explain the difference?
Thank you. Great question. So obviously, as a healthcare provider, I'm very, very concerned about the lack of access to high-quality maternal care. And as you know well, maternal care is really a real spectrum. They're at the moment of birth. It's a joyous time, but it really requires a lot of intervention and special care. I think what distinguishes community health workers from individuals who work in the birthing community is the emphasis on total care for the woman as well as her child, from prenatal services, accessing high-quality prenatal care. And one of the roles that our community health workers have really shined at is having a warm handoff after the mother has delivered and getting that mom and her baby back into primary care. That fourth trimester, that after delivery, is a very, very high vulnerable time period. Postpartum depression and caring for whatever medical conditions may have occurred for the mom during the time of her pregnancy, pregnancy-induced hypertension or pregnancy-induced diabetes, and returning to primary care for follow-up of those is extremely critical. And what I will tell you is our community health workers, because they are seen as a trusted member of that mother's care team, has been able to help us to get those women back in so that they can get their care and their child can get their care. So they're sort of the same philosophy, but sort of different parts of that continuum of birthing care.
Thank you for that explanation. I think we know that in the state of Pennsylvania right now, we need to pull resources to make sure that women are not dying. We're waiting for our maternal mortality report right now. We know that the numbers are still very high. And so right now, community health workers, birth workers, doulas, nurse practitioners, whoever can help, we need to focus on that. So it's important that we understand the definition of a community health worker, how they can help, because when we have places that don't have hospitals, we need to think of alternative care so that women can stop dying. And we know that Black women are dying 3 to 4 times higher. And so we're finding that as we lose hospitals, this number will increase. And I know Pennsylvania doesn't want to see that. So thank you for coming today. We'll continue to fight for the things that we need while we have lack of access on all sides, rural, suburban, urban. Thank you.
Thank you, Representative Curry. Representative Stair.
Thank you for your testifiers for coming today. Am I on? Screen. Can you hear me now? Okay, sorry. What percentage-wise is the approximate split for CHWs serving rural versus urban counties in the Commonwealth?
That's a phenomenal question, and to give you an accurate number, I'd have to come back to you on that. I know that we have representation in all counties of the Commonwealth, but to give you an exact breakdown would be something I'd have to check in on to see if we can partner with the PCP board to get more of that data.
Are there gaps in certain areas of the Commonwealth where CHS are not available or not located?
Not to our knowledge.
It's readily available.
Yeah.
My background is in community health. I did home health and hospice for 30 years out in the communities, and I commend you for the job you are doing and promoting here. So thank you.
Thank you.
If I ma'am, if it is okay, I'd like to just a little follow-up on that. When we talk about workforce development, for our organization, and I believe for many other community health center organizations, the ability to have someone from the community, of the community, be hired and work for us as a community health worker is really an ability to grow our healthcare workforce. I'm going to use the term an entry-level position. That is in no way meant to demean at all, but it can be an avenue for folks to develop a career in healthcare, and if they choose to go on to become an LPN or an RN or a CRNP. In fact, we have one of our community health workers has done just that. He's actually moving up the healthcare continuum, but it was a workforce development opportunity for this young man, and he's done a phenomenal job for us. I'm not going to tell you anything you don't already know, but workforce challenges are a barrier for a lot of us in the healthcare system, in rural as well as urban and suburban communities. And I think the availability of a career as a healthcare community health worker just allows us to open that pool of potential candidates to join our team in healthcare.
Well, thank you. I think it is important that we realize that they're in the appropriate level of care. Going to our rural hospitals and using the Medicaid dollars is what's breaking some of these hospitals and really putting a burden on them. So to have community health workers out within the community trying to grab them before they are going to the higher level of care, more expensive level of care, when we certainly could have addressed things on the street level. So thank you.
Thank you, Representative Stair. Are there any members who are on virtually? I can't see if hands are raised, if they want to have any questions or comments. No. Okay. I mean, one last question. The relationship between a CHW and the patient, is that an ongoing, continual type of relationship as you would have with a doctor?
That is a relationship that never ends. When you run across someone who needs assistance with one thing, typically they need assistance with something else. So from the examples that we provided, it's not just I have a chronic disease, now I need transportation, now I need housing, now I need supports for my children, now I need something else. So it starts off as a one-time occurrence, but it can be lifelong.
Thank you. Thank you. I want to thank the panel. It's been very informative and really appreciate the work that you all do. And we'll move on to our second panel, which is a group of community-based organizations and funders. We have Michelle Nakarati-Chapkis from Women for a Health Environment, Carol Thornton, the Executive Director of Partnership for Better Health out of Central Pennsylvania, and Phil Koch, Vice President Policy and Community Impact from the Pittsburgh Foundation. Do we have an order here that you? Why don't we start with Michelle? Hi, Michelle. Good to see you.
I didn't think that was on here. All right, would you like me to go back, or was I thought I was
That's fine.
probably loud enough.
We heard you,
Okay.
but that's a little bit
And our organization, through a scientific approach, really aims to achieve equitable lives free of environmental harms and hazards, and we do that through community-based programming and advocacy. To date, Women for a Healthy Environment has conducted 163 healthy home assessments. I'm going to talk to you about something that's a little bit more different than the clinical side that you heard about earlier. Our CHWs provide education and a visual inspection of the home to identify potential environmental hazards in that setting. If you think about that, the home is where we spend most of our time. Based on those findings and that interactive process, CHWs provide evidence-based resources that improve that home environment, such as air, furnace, and water filters that they would leave behind for the individuals in that household, dehumidifiers and HEPA vacuums, things like green cleaning tools and integrated pest management solutions that are often important. The education includes addressing environmental concerns, such as those that lead to asthma and allergy triggers, lead poisoning. So we look and identify through a visual inspection potential for lead paint, mold and other indoor air quality issues, and toxic chemicals that could be used in the home, in and around the home. Of those, 90% of the individuals that we have talked with in that 163 amount of visits reported a household income that was below 60% of the area median income. 99% were below 80% AMI. 75% of those healthy home assessment clients identified as a minority population, and there was a child under the age of 6 or a pregnant mom who was present in about 39% of those homes. So here are the stark facts and why this housing work is critical to addressing the myriads of social determinants of health that you heard about earlier, that together create a healthier community for all. 72% of the clients reported that someone in the home had asthma. Of those, 85% were children. An elevated blood lead level, although also known as lead poisoning, was often cited as a concern either at the time of the assessment or it's something that had been diagnosed previously with that family in the home. All the clients reported at least one exposure to what we'd identify as an environmental hazard. That could be exposure to a chemical and household chemical in the home, concerns about air quality or water quality in the home, mold or moisture that has been present in the home, deteriorating paint and pests. As referenced, community health workers provide the clients with the education and the resources to addressing these hazards, thereby creating a healthier home environment for the family. Healthy housing is a basic human right, yet thousands of Pennsylvanians live in communities with environmental risks in the home that harm their well-being, especially our most vulnerable, our children. This limits their ability to grow and ability to succeed later on in life. Our organization receives referrals from physicians, emergency departments, clinics at universities, and federally qualified health clinics. I'd like to share with you just a few examples of the impact of this work. Seeing a child struggle with breathing, ER trips, and medical treatment is the norm for a child with asthma. Women for a Healthy Environment blessed us with a vacuum, air purifiers, and supplies to improve our home environment. As a family, we feel supported and seen. Thank you for advocating for us, the Thomas family. This is a home-based childcare. So these individuals live in this home and open up their home to several children and care for them during the day. Another place that had many people that would be impacted by this environment. This individual said, I used the cleaning supplies from our Healthy Child Care Champion program, and one of my kids who has asthma felt better and was able to breathe easier. I told her mom about these supplies and how much better her daughter did with the changes. Our organization has a HUD Healthy Home Production Grant. As part of that intake and enrollment process, community health workers go into that home and visit the household. Here is what one participant had to say based on the visit. Jermaine was wonderful and listened and heard my concerns. All of you have been a blessing in my life, and I am truly blessed and grateful for this program and everyone in it and involved with it. You were truly an answer to my prayers. God bless you all, and thank you for all of my heart. This is from Ms. Adams. Mia, one of our newer community health workers, recently shared with us last week during our staff meeting. She said while tabling at a community event, she ran into Kendra, an individual that she had done a healthy home assessment for a couple of weeks prior. Kendra was praising the program, stating that she had a carbon monoxide scare 1 week after Mia had left that home. The fire department said that the levels were 19 and that the air purifier that Mia had left behind had likely helped keeping the levels from elevating. And then from another CHW who works for our organization. She had said in her report that she had put into our system after coming back from the Healthy Home Assessment that Donna had experienced breathing problems while walking that led her to visit her doctor to get checked. She also realized that breathing was especially bad on poor air quality days. So the community health worker had shared with her the app for how she could go online and know when the air quality was poor outside. And now this individual uses the app to determine when to adjust her time spent outdoors. And lastly, here is another CHW experience. The parent and her children have allergies and asthma in the home. There is mold in the basement. The outside basement door is rotting, and there is a hole at the bottom. There are also mice and rodents that come in and around the property. There are a lot of structural problems in the home, and Heather doesn't want to get on the landlord's bad side. The CHW left behind a dehumidifier for the basement, air filters for the home, green cleaning supplies, and an eco-friendly pest management trap to avoid bringing other toxics into the home. Following these assessments, 3/4 of the household indicated that they need for additional assistance. So the question that was asked, do you continue to follow with these individuals? The answer is yes, because now that relationship has been built and it's ongoing. So this includes contacting our organization either at the time of the assessment or following it, additional assistance that is needed for things like utility payments, food insecurity, landlord and tenant issues, asthma care management, and employment issues. Of the clients who request additional assistance, 92% of them requested assistance in one or more of those categories that I had just described to you. Without the engagement and interaction with a CHW team member, these needs would go often unmet and unheard. CHWs make referrals for utility assistance programs like LIHEAP and contact water authority systems for assistance with their programs, community assistance programs. And they also help to connect clients with local food banks and pantries, legal assistance, clinical asthma care providers, as well as information about job fairs. This is the real work of CHWs that focuses on primary prevention of health risks. It builds a stronger community and contributes to a healthier economy. Research has informed us that a healthy home provides physical and mental health benefits, supports child development, advances economic stability, and reduces healthcare costs. CHWs are integral to a healthy, thriving neighborhood. Community health workers play a vital role in mitigating all of these challenges that I described to you. They're embedded within their communities. They build and maintain trust, as you've heard often in the previous panel. They understand the local context. They effectively connect with individuals and the critical resources that are needed. Their lived experience allows them to establish a positive relationship with the communities that they serve. The CHWs meet people where they are. So I hope that the stories that I shared with you have demonstrated the critical need of the workforce. Currently, the limited capacity of CBOs, like our organization, to bill Pennsylvania Medicaid directly hinders our ability to sustain our CHW programs. We have had 6 individuals who have been certified and trained as CHWs. Our strategic plan calls for expanding that work and that workforce all across Pennsylvania, but right now we're limited in our ability to do that. A train-the-trainer model would be a really exciting opportunity for us to endeavor on. So the funding limitation creates an unacceptable barrier to accessing this critical evidence-based community-level intervention to improve the health of vulnerable populations. I anticipate that by the end of the year, though, we'll have the technology and the paperwork and working with some consultants to really to have the ability to be in compliance, because we think about things like HIPAA compliance and such things that we have to get well suited for, and we're on the path of doing that right now so that we can be fully equipped when the day says go, that we're ready to go along with them. So CHW services, as we know, are unique and deeply embedded in the community, but the billing and the policy procedures for the services require, frankly, a unique and a non-clinical approach, and that one such that minimizes the barriers for community-based organizations such as ours and all CHW employers across the state to really participate equitably in billing and ultimately make the state plan amendment successful. The Pennsylvanians who would benefit from CHW services should have access to these services, but this will only happen if the employer types that participate in the Medicaid assistance program and the notable barriers that exist, as I had described, the community-based care management program that was informed that were available to us, to others were not available to us as a nonprofit organization. So in closing, as I've shared, many Pennsylvanians, particularly those in underserved communities all across the Commonwealth, experience disproportionately negative health consequences due to the environmental factors, as I described earlier, including inadequate and unhealthy housing and lack of community spaces, green spaces. So these environmental determinants of health significantly exacerbate existing health disparities and drive increased healthcare utilization. We urge you to recognize community health workers and create a sustainable financing mechanism for them under PA Medicaid. This will be an impactful investment in the health and well-being of Pennsylvania communities, improve the health outcomes, and reduce healthcare costs. I thank you for your time and your consideration.
Thank you for your testimony. Ms. Thornton?
Good afternoon. Thank you, honorable members of the House Health Committee, for this opportunity to share why sustainable funding is important to community health workers. I'm Carol Thornton, Executive Director of the Partnership for Better Health. The partnership is a local health conversion foundation created by the sale of the Carlisle Hospital in 2001, just west of here. We champion, invest in ideas, initiatives, and collaborations to ensure everyone in our communities can reach their highest potential for health, and that being in Perry County, parts of Cumberland and Adams County, and the Shippensburg area. Through our grant making, we have been able to support community health worker services that can reach the community members that need them the most. And you've heard a lot today of what that looks like. And we knew that there was tremendous effectiveness in supporting these type of programs. So since 2001, we funded our own federally qualified health center, Sadler Health, and to employ community health workers in our area, as well as we actually provide funding for a flexible fund to help the community health workers meet the needs of their participants on the spot, whether it's food, transportation, or such. Probably what's most important to us is that since 2021, they've helped 344 individuals in that in-depth relationship building process to connect to services like getting insurance, accessing medical care, behavioral health, dental, and then access to emergency food and housing, as you've heard from the other speakers today. Also in 2022, our foundation also supported our local workforce development and training provider, Employment Skills Center, to provide free community health worker training. So it's a free 10-week, 1-hour course that follows the accredited process that we have in Pennsylvania, and it prepares them with specialized training and skills to become a successful community health worker and eventually be certified. The cost to our foundation is just $1,500 per enrollee. We see that as a wonderful investment into providing that person with that ladder to go help the community, be a community health worker, and whether they become a social worker later on or a licensed practitioner, like we've heard today, it's a tremendous way to create that community focus in the delivery of healthcare in our community. So local foundations such as ours continue to play a crucial role in funding community health worker positions and demonstrating a strong commitment to the improved outcomes that we want to see in Pennsylvania communities. However, that continued success and expansion of these vital programs require a sustainable funding mechanism that complements the contributions of the foundations. Unfortunately, our financial resources are not unlimited, and we cannot fully scale the community health worker efforts across Pennsylvania unless there's a more sustainable funding mechanism. So recognition for community health workers under Pennsylvania Medicaid would offer that structured reimbursement system and would address this crucial gap and enable the significant expansion and sustainability of these existing high-impact programs. Partnership for Better Health urges you to support community health workers across the state. Without sustainable financing, we will have communities without these vital community health workers to help individuals reach their highest potential for health. Thank you.
Thank you. Mr. Cope.
I'll start by saying thank you. It's tough being the last presenter of 6 panelists, but I'll do my best. So thank you for your time and your patience. And thank you for the opportunity to provide testimony urging you to support recognizing community health workers in Pennsylvania under Medicaid. I'm Phil Koch. I'm the Vice President of Policy and Community Impact at the Pittsburgh Foundation, where we help fund the training and placement, deployment, and network building and continuing education of community health workers in priority neighborhoods throughout southwestern Pennsylvania. We've also served as the fiscal agent for the Pennsylvania Community Health Workers Collaborative. And I'm here to speak to you on behalf of our community foundation and our president and CEO, Lisa Schroeder, but also on behalf of many of the foundations in southwestern Pennsylvania and across Pennsylvania that have invested large sums of grant funding for this work. So I asked the question, why? Why did our foundation and many other foundations choose to invest millions of dollars in community health workers over the last 5 years or so? Well, in both urban and rural communities, community health workers significantly improve health outcomes by connecting folks experiencing health inequities to critical resources and providers. Community health workers improve healthcare access, adding value to healthcare teams and enriching quality of life for patients and clients. Community health workers play an essential role in our healthcare systems, helping to improve overall public health and driving down healthcare costs. And because community health workers, as we've heard, often live in the communities of which they serve, they often share ethnicities or languages, socioeconomic status, or life experiences, and they become that trusted partner on the healthcare team because they understand their neighbors and their situations. When COVID hit, community health workers were instrumental in improving health outcomes. They conducted community contact tracing, they did COVID testing, they did vaccine education, and connected vulnerable residents to food and housing, PPE, and other supports. We see 5 ways in which community health workers continue, since COVID, to play a vital role. 1, they increase access to health care. Community health workers act as navigators, connecting individuals to those primary and specialized care to provide those important services that they need. Number 2, they improve health literacy. So community health workers empower individuals and families by sharing knowledge about health conditions, preventable diseases, and self-management techniques. Number 3, chronic disease management. So community health workers support and educate people on chronic illnesses, helping to make sure that they're adhering to those treatment plans so that they can stay on track. Number 4, disease prevention and health promotion. Community health workers deliver vital preventative services, including vaccination, healthcare screenings, and health education targeted to populations. And number 5, they reduce hospital readmissions. Through follow-up care and other interventions, they make sure that folks are not re-entering the hospital system once they are dispersed. So although they have been around, community health workers have been around and throughout the state and nationally for years, in Pennsylvania, community health workers tend to be under-organized or under-resourced when you compare them to the other states. And we are behind in efforts to formalize that community health worker role. On the contrary, local foundations like ours have recognized the value of community health workers and supporting community health workers over the last several years, and our investments have served to amplify the impact of community health workers as we start to solidify that work. These investments highlight the recognized value of community health workers and underscore the critical need for sustainable public funding and policy support. As a research paper states, while community health worker programs have long been an underfunded afterthought, they are now front and center as the emerging foundation of our health system. Despite this increased attention, community health worker programs continue to face pressing challenges: inadequate financing, lack of supply and commodity, low compensation, and inadequate supervision. Now, due to the fiscal cliff of $1.1 billion of federal ARPA and CARES Act funding for community health workers, including more than $19.9 million lost in Pennsylvania for Pennsylvania community health workers, community health worker programs are ending across the Commonwealth. This is not a distant threat, but it is a current crisis that requires immediate action and attention. We must secure long-term government funding and Medicaid reimbursement for community health workers. Philanthropic dollars, like those provided by the Pittsburgh Foundation and our partners, are intended for short-term bridge support, while organizations like the Pennsylvania Community Health Workers Collaborative work to secure long-term sustainable funding, structures, and supports. Pennsylvania faces many critical challenges right now within our healthcare system. Nurses and other clinical worker shortages, disparities in healthcare, and the ongoing need to lower cost and improve outcomes. Community health workers are in a perfect position to help us address each of these threats to promote positive health outcomes. With sustainable state investment, community health workers will improve the overall health of Pennsylvanians. Community health workers will reduce healthcare costs through preventative care and reduced hospitalizations. Community health workers will address health disparities in underserved communities. And finally, community health workers will strengthen the state's public health infrastructure overall. As members of the House Health Committee, we urge you to contact the Department of Human Services and encourage their efforts to develop a sustainable financing mechanism or consider future legislation that would sustain community health worker programs in Pennsylvania, including recognizing community health workers under Pennsylvania Medicaid. Your advocacy and support are critical, and we welcome an opportunity to discuss this further at your convenience. Thank you.
Thank you for your testimony, and let me express, I think, on behalf of all of us to our foundation community, thank you for supporting this program. It increases access, and you can count on us to be advocates for amending the state plan in order to do this. I mean, I remember having conversations with the department on the issue of Medicaid reimbursement for street medicine for our unhoused population, and we were able to get that done without legislation. Legislation would probably be the least preferred way to proceed
I would
here.
agree with that, yes.
But thank you for what you have done to help sustain this program. I want to ask Michelle, can you talk a little bit about the referral process? How do people get connected?
Sure, there are multiple different ways. So there's a couple of systems, both referral in and referral out. So the referral in to us happens through the many different practitioners in the community that I had mentioned earlier, as well as Find Help. Highmark has a referral system, 211 and United Way. So there are multiple agencies where people are in those systems and they can refer them out. So if they know that our organization has community health workers who go into the home and provide those services, we can get those individuals connected. And then when we do the referrals out for other places too. So as an example, I had mentioned Jermaine, and so she lives and works in Clairton. So she knows where the food pantries are in Clairton, or she knows the faith-based organizations that are there, perhaps her churches that have food pantries, and she can call over and refer those out. We work with Neighborhood Legal Services, Community Justice Project, and Fair Shake. Those are all organizations. Just Mediation, all four of those help then to provide landlord-tenant resolutions, and so we refer out to all of those as well. We refer out to the county for transportation so that they know the Fair Fare program, in addition to having this loop system where there might be a clinical need, and so we can refer them back to the federally qualified health clinic that might be in the neighborhood as well.
Thank other members. Representative Stair.
Thank you again for your testifying. Has there been a recent study, whether privately or through government entities such as DHS or the Legislative Budget and Finance Committee, of what the estimated cost would be if CHWs were authorized to directly bill Medicaid?
I don't have the answer for the direct cost, and so I'll turn it over to my colleagues who may have that, who spoke earlier. But one of the things that I am keenly interested in, as you heard, we have multiple community health workers, and so we go to the foundations and we rely on those grants. And so we go, and oftentimes they're an annual grant. So we can put in our grant and perhaps the funding is there. And if not, then we have to try and figure out another pathway to keep those individuals employed because they're bringing significant resources to that community. And so for that reason, we're looking at the reimbursement aspect of it to be the sustainable model because we know that prevention happens. Our organization prides itself on research and science and we turn to that. And so we know that prevention works. But in terms of the dollars and cents, I should turn it over to Phil. Did you have an answer for that, Phil?
I just know that that was certainly a question that has been raised. That was a question that was also posed to DHS to really help us better understand that. And I know that we have not received an answer yet. So I might
Nothing close or just a
ballpark.
couple trillion here, a couple trillion there.
No, I'm sorry, I don't have an answer for you. We can certainly continue to press DHS to look for those answers.
Yeah, because
but
I
I'm-
think it'd be pretty expensive. But I also wanted to ask, with the landlord tenant, that woman's house that you were describing, sounds like we might want to invest in code enforcement officers. I mean, you have mold in the cellar, you've got.
We have those relationships as well, certainly.
Well,
yeah.
Rats running around.
So, believe it or
lead
not-
paint. When have we done lead paint last? I mean, these are issues that usually code enforcement really addresses for the health and safety of people. That's a landlord issue.
Interestingly enough, as I had mentioned, in all of those 163 visits that our community health workers had done, mold was found in 90% of those homes, and it's not a code enforcement issue.
Well, it should be. It's a landlord issue,
It
tenant
absolutely,
issue.
it should be, but
And,
it's not recognized by the health department. And so that's a whole other policy problem that we're trying to get addressed.
That's a shame because the landlord's collecting lots of money, maybe even subsidized money, and you're telling me it's full of mold and basement rats and everything else like that. They are health hazards, and those are things that should be addressed, not so much. I have a concern, this is going to be a very expensive endeavor. I have 80-year-old women widows who can't afford to pay their electric bill, their meds, their food, their heat. They do without a lot. They're still trying to keep their own home up and running and paying lots of taxes to do so. So to ask them to spend a little bit more on issues like this here, that there's some slumlord not being addressed to have to take care of with lead paint. When was the last time we had lead paint issues? Are kids still chewing on the windowsills?
Unfortunately, in Allegheny County, we still have of the children who are screened, which is about 21,000 a year, upwards of 4 to 5% of those children, well over 1,000, closer to 2,000 now who have identified as lead poisoning. So lead poisoning is today in 2025 is still a real problem and a significant problem. And so, certainly I think that as we look at the low cost, no cost approaches, as I'm describing that community health workers do, make a significant impact. So they can say, put contact paper over top of that peeling paint to reduce the exposure.
I mean, I don't think lead has been put in paint for.
Unfortunately, we're the fourth oldest housing stock in the country. So we're dealing from this historic aspect of having just really old houses.
Which again would be a code enforcement. If you're going to rent out, you need to be inspected by code enforcement to see if there's lead paint in a home or some of these molds growing around in unhealthy environments for these people. I'm saying, convince me to tell me why my little old 80-year-old widow should be responsible because she already can't pay for her meds. She's not eating healthy because she can't afford her food. She's living paycheck to paycheck because she cannot afford to keep her house warm. And now we have slumlords not taking care of their properties, and now it's this little old lady who's paying her taxes. Fault? I mean, I think we have
I
to.
wouldn't even say that oftentimes it's even slumlords. I just think it's old housing stock and generational transferring a home from one generation to the other and lack of maintenance over time. But what I'm describing are some of the things that I had shared with you, like the pests and such. We can do things that are, again, the low cost, no cost approaches that really then in turn leave a healthier home environment by one visit. By spending 2 hours with that household, then we can leave. And the families that we're seeing, we focus our efforts on homes with children in the environment in that particular home setting because they are the most vulnerable, they are the most impacted from a health perspective, and that's where we put our resources, is that it's mostly families, probably about 95% of the families that we see then have children in the home. So we're really creating a healthier environment for those children so that they have a healthy environment to live in, to learn in, and then hopefully to thrive in as years go on.
Well, like I said, if it's that unhealthy, maybe kids shouldn't be living there. Why should my little old 80-year-old woman be responsible to take care of a property that's probably already paid for by the government or assisted by in the government to provide all these extra things? That's a landlord's issue. He's getting paid quite well to take care of these properties, and I think maybe we want to look at that more so than have, like I said, my little old lady who can't afford to pay for her medicine and her food and her heat. Thank you. Thank you very much.
Thank you. Before I get to Representative Torzik, are there any members online who have a question or comment? I don't see any. Representative Torzik.
Thank you, Mr. Chairman. Thank you for the testimony. Mr. Chapkus, you further indicated that, I'm sorry, I can't see. Okay. You further indicated that community-based organizations cannot bill Medicaid directly. To clarify, are CBOs included in the proposed state plan amendment that DHS is working on? If not, are there discussions to authorize direct billing to Medicaid by CBOs?
So from our perspective, we were not able to tap into the system, and I'll make sure I'm calling it right. The community-based care management program wasn't available to us at the time of discussion, and so we wanted to make sure. I had mentioned that, well, perhaps there are things that we have to do to equip ourselves to become eligible should that opportunity down the road pass and be ready to go. So as an example, there's been discussion about your computers and HIPAA compliance and things of that nature, and how we might be able to enter into agreements with these various health systems. And so that's the framework that we're building out now, so that if it does change and we're able to access those funds, then we'll have all of the legal requirements in place to be able to do that. And we anticipate that we'll be able to do that by the end of this year.
If I could comment as well, I think it's also important to go back to DHS and find out what their intent is with the state plan amendment. From what I recall at the beginning, they were very open to various entities being able to bill, but in the last iteration, it was limited to just health management organizations, did not include federally qualified health centers nor community-based organizations. But we know that over 50% of those that are employed as a community health worker are at those organizations.
Okay, that's very interesting to note, because that's, we're still going to leave 50% of the angels out there who are working behind. I think the community health workers are such an important advocate, and I really appreciate the testimony you've given us. I'm in a small community, and we are trying our best to recruit healthcare. The good news is our community has grown nursing programs with our Penn State branch campus, and our Alvernia College Town has come in along with our hospital groups, and that's a wonderful way to get started. But again, if we can get the community-based people in, and if they like what they're doing and have an opportunity then to move into our community education program, because Alvernia has put in programs that are going to be weekend and night programs, so it gives more opportunity for people to improve their their place in life and to continue to serve. So thanks for all you're doing. I really appreciate hearing from you today.
Representative Steer.
I do also want to commend you. These are wonderful resources to have. We all know they go to the hospital, they get social workers, social services. As soon as those patients are discharged, they're out the door, and there is no further follow-up in the communities and stuff like that. So I do see this as a huge resource. I'm not stuck on the let's do the landlord-tenant rebuild their houses and paint their houses thing. But
small issue of the
when
whole-
we're looking
yeah.
at Medicaid dollars going towards the resources for whether it be mental health, drug addiction, because they're the people who are kicked out of housing and everything else like that. I think I do see a huge benefit, but thank you very much for testifying. Thank you.
Thank you, Representative Stair. I want to thank all of you, all of our panelists today. You put a real face on this issue, and ultimately what we're talking about here is, just even from the financial standpoint, I think a way to save money through in the healthcare sector overall. I mean, prevention. This is a lot about prevention, keeping people out of the emergency room, keeping people from accessing providers in the worst moments, as opposed to trying to get, making sure people access preventive care up front, and all the other things that the social determinants to fill in those gaps ultimately end up, I think, saving taxpayers money and improving the health and welfare of those in the Commonwealth that are most vulnerable. So I want to thank you for the work you do, for the funding you provide, and the advocacy that you're doing, and you can count on many of us to help hopefully move this forward with the department, because it makes enormous sense from so many different perspectives. Again, thanks so much for being with us today. I look forward to working with you in the future.
Thank you.